Hello, everyone. Happy Saturday. Uh, it's April's Fools, but we're not going to be making a lot of jokes today. Hope you're all doing well. I'm so excited to have this management reasoning report today with everyone. We started the series last week. Essentially, this is our second session where we try to focus on what to do in the management of common cases in medicine. We don't have any discussant in particular. This is going to be an open discussant. Usually, we would prefer if you would open your cameras and we can all like answer questions. If you open your camera, I can ask you questions throughout the conversation, and these are usually like general questions. They're not going to be pimping or anything that's going to be like specific, but just to like facilitate the discussion. I see Hadi is a research fellow at Emory. Nidhi was my intern. Hey, Sarah, Karthik, Daniel, hi, everyone. Okay, so I'm excited to start. Maddie, would you be able to share the whiteboard?
Definitely. Let me go ahead and share that.
Thank you so much.
All right.
Okay, so this is a case of a 60-year-old male with past medical history of type 2 diabetes, hypertension, coronary artery disease. They have a history of a drug-eluting stent to the LAD, left anterior descending artery, presenting for lower extremity swelling, orthopnea, and paroxysmal nocturnal dyspnea. Their home meds include metformin, aspirin, and statin. They don't have any surgical history. They don't smoke or drink or use any substances. Their review of systems was positive for cough, dyspnea on exertion, no fevers or chills. They're jumping to vitals and exam. So they're afebrile, the temperature of 37.0, heart rate of 95. The blood pressure was 170 over 100. The exam was notable for a JVP that is at 30 degrees close to the angle of the mandible, 2+ lower extremity edema, warm extremities, and we did an EKG at that point, which, to simplify the read, which I'm not going to go into detail, had signs of LVH, but no other findings of ischemia per se. Just to initiate the discussion, I know what is the diagnosis that we're thinking of here, and I know it's already on your mind. Same as saying congestive heart failure, yes, and concern for heart failure, yeah, exactly. So we have concern for heart failure, and I wanted to ask you all if we wanted to break down congestive heart failure into signs of left heart failure and right heart failure. What signs do you think of for right heart failure?
Usually people can have the elevated JVD, they'll present with early satiety, so they might have a distended gut, and then lower extremity edema, that there's probably some kind of right heart involvement.
Yeah. Thank you, Nidhi. And yeah, I completely agree with that. And what would you all think of if there are symptoms of left heart failure per se? Yeah, I see in the chat, same as saying dyspnea. I see pulmonary edema, crackles, shortness of breath. Yeah, and And takes us to the first point of discussion, is that separating the symptoms of left heart failure and right heart failure, like you all said, the JVD, edema, and ascites can be signs of right heart failure, while left heart failure, we think of orthopnea, hepatojugular reflex per se. One thing I wanted to add is that one symptom that has been recently described is called bendopnea. And that's a sign when somebody bends forward, for example, to tie their shoes. It's been associated with increased filling pressures. And this has been studied in the last 10 years again, it got validated to be associated with elevated filling pressures. And I find that incredible, is that they described a symptom, like something we can ask for a disease that has been there for thousands of years. And that is one thing you can add to your armamentarium, that bendopnea can be a sign of left heart failure. I wanted to see, in this case, for this patient, are we thinking left heart failure or right heart failure? Excellent. Yeah, and like I see in the chat, people are saying both. And how would you reconcile the fact that they have heart failure on both the left side and the right side per se? And my question to everyone is, would you see lower extremity edema with left heart failure? Because when I think of left heart failure, for example, most of our patients usually typically have edema. How do you all think of that? Excellent. I see Ricardo and Daniel telling us about the backup from the left heart failure causing pulmonary congestion, causing the right heart failure. Ricardo or Daniel, do you want to share with us your thoughts, if you're able to?
Hi. So happy to be here.
Hello.
I hear you now.
Okay. So essentially is I think the mechanism is when you have a left heart failure, there would be fluid backing up into the lungs, and essentially those fluids will eventually back up to the right ventricles of the heart, and that would cause both left heart failure and right heart failure, which also causes the fluid back up to the system that causes the systemic edema.
Wow, Daniel, that's excellent discussion. And thank you for sharing your thoughts with us and opening your camera. Is this your first time joining us on the
Yeah,
virtual?
this is first time.
Wow, can you tell us about yourself? Just like, we don't have to go into details, but yeah.
Oh, yeah, sure. I'm an IMG from Indonesia who just matched into Jersey Shore. So excited to start this early on before residency.
We are so excited for you. So glad you're able to join us. Thank you for discussing with us. Congrats.
Thank you for having this. Thank you.
This is why I love this community. We're literally from all over the world. If we poll how many languages are in this group, it would be, I'm pretty sure, at least 15. Thank you. So I have a question to everyone. Why is it that sometimes we might see edema with left heart disease alone? And this was a thought that I had, is that in my experience, a lot of the patients on who have just left heart failure might have lower extremity edema. And after looking into it, essentially there seems to be other mechanisms, including elevated renin, angiotensin, aldosterone systems, and then volume back up into the right heart, like you're saying. But if there is volume overload without right heart failure in the initial stages, just by the Frank-Starling mechanism and like the fluid backflow, you might have signs of edema, signs of volume congestion that might cause edema without right heart failure, but this mechanism would eventually lead to right heart failure. And in a sense that it's a spectrum and not necessarily a on-off, or right heart failure necessarily has to be there to cause the edema, but in a sense that the volume overload, the backup of fluid might in itself cause the edema. And that's something that was like a learning point for me from this point. So thank you. And then now that we're thinking this is heart failure, how do you all assess the signs of perfusion, or what are the signs of cardiogenic shock that you think of when you're evaluating a patient with heart failure? I see Johnny said cold extremities. Excellent. Low capillary refill, oliguria. Excellent. And I agree with these findings, in addition to decreased pulse pressure, which is the difference between the systolic and the diastolic pulse pressure. That's also a sign of early shock. Cool extremities. Lethargy is a big one. Altered mental status. Tachycardia, elevated lactate, hyponatremia, elevated troponin, and these are all signs like you're all saying. Aisha, do you want to tell us your thoughts about how you would assess, for example, for these signs?
Hi, can you see me?
Yes, we can.
Hi, my name is Aisha. This is also my first session joining in. I'm from Bahrain. I attend a Irish medical school, and I just graduated last year. And I would assess for cardiogenic shock with, as I said, with a weak pulse and a low blood pressure.
Yeah, thank you for joining, first of all. We love that you're joining, and this is like why I love this group. Yeah, so I agree. And Aisha, are you trying to come to the US, or this is just, you're just joining for the education?
Yeah, I'll be applying for IM and hopefully cardiology.
Wow, that's exciting. I'm glad that I could hear from a future cardiologist.
Fingers crossed, yep.
Yeah, so thank you. Yeah, I agree with what you said. So a weak pulse, low blood pressure can be a finding of early shock. Just going back to these pesky terms that we learn in statistics, that we have just to remind you of sensitivity and specificity. A sensitive test is a test that is good to rule out a diagnosis per se, and a specific test is a good test to rule in a diagnosis. A sensitive test in medicine, for example, would be ANA in lupus, and that if ANA is negative, you can fairly confidently say that this is likely not lupus. A specific test is a test that once you have as positive, you're pretty sure that that's your diagnosis. For example, a positive blood culture for staph is likely for two and two blood cultures, for example, are likely specific for a bacteremia. It can't be any other organism. It's technically specific. And all of these things that you are all saying, for example, decreased pulse pressure, SBP, lethargy, altered mental status can help you make the diagnosis, but there's no sensitive marker for cardiogenic shock or low perfusion. And that is something that for you all to keep in mind, is that like we wish that there was an ANA for cardiogenic shock where we just order it and we say, oh, they definitely don't have cardiogenic shock, but it's a litany of these tests that we can order and think of and ask, and can help us think of that diagnosis. So in this case, we saw that we're likely the patient is likely perfusing, so they're warm. We're not having a decreased pulse pressure, and they're not cool. They're not altered. They're and then so we can move on to the next aliquot. So on labs, the sodium was 135, the BUN was 40. The creatinine was 1.5, hemoglobin of 10, with an MCV of 80. The BNP was 700, and the troponin was normal at 7. Okay. Any thoughts regarding these labs, or any like first thoughts that come to your mind?
So just starting with the sodium, it's 135. So that's, that's still normal, but let's say that it was lower than that, I'd probably be more concerned about the patient, since hyponatremia is associated with worse prognosis and heart failure. And then looking at their creatinine 1.5, so it looks like it's abnormal. I'm thinking, could this be because of, their blood pressure? Do they have a history of increase of CKD, or is it like a cardiorenal type of situation where they're having increased creatinine because of congestion? And then looking at the hemoglobin 10, I'm like, is this somebody that might have like heart failure with reduced ejection fraction, just has like a low iron secondary to that, or like chronic inflammation? And then for the BNP, it seems it's elevated, definitely at 700. And yeah, the troponin's within normal limits. That's a good sign.
Thank you so much. Nidhi, do you want to tell the crowd just who you are, or what do you want to do in general?
Oh yeah, sure. I'm Nidhi. I was Yusuf's intern on one of his teams. I'm a first year at Emory, and I'm interested in cardiology, currently on the cardiology service. So I'm seeing a lot of this.
And just to rephrase that again, I was a resident on Nidhi's team, and she's a future cardiologist. So I'm so glad to be hearing from another future cardiologist. I love that. Nidhi, that's exactly how I would analyze those labs, like exactly the same way I would think about it. Just to like ask, do you think, is the BNP specific for heart failure or not? Could other diagnoses of volume overload cause an elevated BNP, or is it exclusively in heart failure? Yeah. Thank you, Seema, Ishad, Nidhi. Exactly. So BNP is not necessarily specific for heart failure. There are some factors, for example, that any etiology that will volume overload, where there's like a dilatation of the atria/ventricles, can elevate the BNP, like Hans was saying in the chat. So there's like strain on the heart per se. There are Entresto, for example, the sacubitril valsartan medication can elevate the BNP. Patients with chronic kidney disease tend to have higher levels of BNP. And then there are some diseases or illnesses that may lower the BNP. For example, obesity and it can lower the BNP, which might make it less sensitive per se. But typically, the general thought is that if an elevated BNP, it's like more than 1,000, you really have to think of volume overload in general and try to think of heart failure in specific. And then if it is low, less than 100, it would make heart failure less likely, although with some caveats. For example, like HFpEF would not necessarily have a super elevated BNP, and like you're all saying, Bea, Hans, thank you for participating. Okay. Yeah, and I see in the chat, even a PE can cause a BNP through recurrent heart strain per se. Good, good. Thank you. So we did the echo, and like you all surmised, the echo showed a grade 1 diastolic dysfunction and a reduced left ventricular EF at 35 to 40%. So I think the diagnosis of new acute decompensated heart failure is likely at play here. What is the etiology of this heart failure? Or what etiologies do you all think of in general? Yeah, Shema, are you able to open the mic or no?
Yes, I was thinking of left-sided heart failure due to hypertension, because we have seen its diastolic dysfunction, and the concentric hypertrophy leads at the beginning, as far as I remember, to preserved ejection fraction, and it goes in with diastolic dysfunction. And I think later in the stage, it can also go to reduced EF, but I am really not an expert in cardiology, so please, any cardiologist here, step in.
I think that was very accurate. Thank you. And what other etiologies do you think of? So we saw here, Sarah said valvular disease. Perfect. And any other thoughts you all have? Or what do you think of when you have a new patient with heart failure? Nidhi is saying ischemic versus non-ischemic. Sarah, are you able to open your mic or no?
Oh, yes, I can. Yeah, I also think about, like, I think the three most common causes are going to be ischemic hypertension and valvular heart disease, but like less common will be toxins, like certain drugs like doxorubicin, and also alcohol associated.
Yeah, love that. And exactly, so there are, we have a CP solver schema for new HFrEF with all of the etiologies, and it's like an excellent schema, which I absolutely love. And applying the first filter would be, the most common things would be like you all said, hypertension, coronary artery disease. Given how common hypertension and diabetes, like Bea is saying, and these are all risk factors for coronary artery disease, and those will predispose as like the number one, like most common causes, and then all the other etiologies that you're all thinking of. So like you're saying, genetic causes, nutritional deficiencies, high output state, valvular heart disease, arrhythmias, and these are all things we have to work up on the go as we're working up this patient for this new diagnosis. I'm not going to go into that further for this patient in particular, but I'm just going to jump to the next part. So we oftentimes classify patients with heart failure when they're admitted as either, we draw an axis, basically a 4x4 table, 2x2 table of essentially, are they warm or cold, or are they wet or dry? And based on this table, 2x2 table, we can decide the management. And like we said, so for example, warm and wet is, so like this patient is where your mainstay of therapy will be diuretics. While if they're warm, or they're cold and wet, or they're cold in general, you start thinking of cardiogenic shock, and this is where you start thinking of inotropes and further therapy to support this patient. And this is a framework I want you to have for every single patient that comes into the hospital and with heart failure exacerbation is put them on this axis of where you think they are. And this is can evolve the hospitalization, but and not fixed, but that's something I want you to help you frame your patient as you are presenting them. What do you all want to do for this patient? Yeah, Sarah with a direct application. This person seems warm and wet. Exactly. And like you all said, giving diuretics. And Daniel, thank you for wow. Yeah, exactly. So diuretics can consider vasodilators too. Brahim, do you want to tell us your thoughts?
Yeah, hi everyone. I'm not sure if you can hear me.
We can.
Yeah, this is my first time here. I'm a medical student based in Saudi Arabia. I'm Sudanese by citizenship. So I think as we have discussed, and it's actually very nice being here with all of you guys. Also, thank you for organizing this, and thank you, Yusuf, as well, for facilitating this session and for presenting this amazing case. So I think as we have discussed, this patient appears to be volume overloaded, so we can all agree that they're wet. And then they're also warm, right? So they have their cardiac output. And then, so we would generally, in order to relieve the volume overload, would go with loop diuretics. And then we can see from there on how well, I would assume that this patient would be in the inpatient ward. So through follow-up, we can see if they're getting better or not. If they're not, we can consider hydralazine and nitrates or ACE inhibitors and ARBs as vasodilators. In addition to the furosemide.
Wow, Brahim, thank you for joining. Which med school class are you now?
I'm currently MS3, so I've just started my clinical rotations. I'm currently doing internal medicine, actually.
Oh, that's wonderful. And what are your plans?
For the time being, I mean, internal medicine for sure, but for subspecialty, I think it's a little bit too early for me, at least.
Yeah, there's no rush at all. And I wish I was joining CP Solvers when I was a third-year med student. This is amazing. Thank you for joining. And what a great answer. And yeah, so like you're all saying, so the inpatient management, likely diuretics, blood pressure, everybody's focusing on the blood pressure. I love that. And then, like we said, it's for blood pressure and vasodilators. Can we think of preload and afterload? And we can give afterload reducing agents in patients along with preload. So after we start diuretics, I saw Daniel said ACE and beta blocker. Can you tell me more?
Yeah, so my thinking is that other than the loop diuretics, we can also use ACE inhibitors other than to vasodilate, and also for the to regulate the angiotensin system, which has a loop effect on congestive heart failures. And I've also read that beta blockers is also but I think beta blockers is after the congestive is treated. So later on, we'll give beta blockers because I think it has a positive correlation with mortality rates in heart failures, but after the congestion is treated, not at the moment.
Brilliant, Daniel. And that's actually right. And you said there's like a mortality benefit. Does anybody know what we call these medicines that Daniel is mentioning that potentially have a mortality benefit in heart failure? So we just mentioned ACE and beta blocker. Yeah, guideline directed medical therapy.
Oh,
so what?
I think SGLT inhibitors also have mortality benefits too for heart failures.
Amazing. And so far we mentioned SGLT2 inhibitors, beta blocker, ACE, and Nidicent MRA, which is mineralocorticoid receptor antagonist, or for example, spironolactone. So this is a very commonly tested question on STEPS. They ask you what are the medicines that helps with mortality and heart failure with reduced ejection fraction, and the name for them is guideline-directed medical therapy, like Sarah mentioned, and the acronym for it is GDMT, so guideline-directed medical therapy. And I had a hard time remembering it in med school, but I came up with the mnemonic BAMS, so BAMS. So the mnemonic is for beta blocker, ACE/ARB/ARNI. M is for mineralocorticoid receptor antagonist, and S is for SGLT2. And this is for reduced ejection fraction. Hopefully this can help you remember that these classes of medicines have a mortality benefit and reduced ejection fraction. And Sarah is asking, when do we start these medicines and the addition, or in what timeline do we administer these medicines? So this is an area of like debate, but essentially, once you have a diagnosis of heart failure with reduced ejection fraction, you are off to the races to getting these patients on GDMT. GDMT medicines like save lives, and if you start them on maximal therapy, you could potentially improve their ejection fraction, improve their quality of life, decrease their hospitalizations, and it's off to the races. There have been many proposed mechanisms towards how to start a GDMT. So there have been, for example, conventional sequencing methods is that we start the ACE or ARB, and then once we're sure they're out of an exacerbation or closer to out of an exacerbation, start a beta blocker and then start the rest of the medicines. Another method that's been recently proposed is rapid sequencing, is that some providers start beta blocker and SGLT2 inhibitor together, and then following by that start with an ACE or an ARB or an ARNI, and then a mineralocorticoid receptor antagonist. But what I want you to take from this is that once you have this diagnosis of reduced ejection fraction, the race has started and we're off to the BAMs, and we want to get them started on these medicines, get them the close follow-up as soon as we can, and get them started, and so that to help with their diagnosis. Nidhi was saying there's some attendings who prefer starting everything at once in small doses, and that is something that's also recently been suggested, and this has still hasn't had any uptake basically among all providers, and it's still like evolving, just because people are usually worried about kidney function and things like that. And but yeah, so essentially the race has started with the BAMs. Last two teaching points I wanted to go through. So we saw that the patient has a creatinine of 1.5. Their baseline is 1.0. Does that make you hesitate to diurese them, or how do you think about that? Ricardo, do you want to share your thoughts?
Hi everyone. Earlier my connection like went off, so I don't know if I already introduced myself, because I think I was talking alone. So I'm from Colombia. This is my third time on CPS Solvers, and yeah, so basically there's like a 50% rise in the creatinine, so that would like tell us that is an acute kidney injury, or at least grade 1 acute kidney injury.
Yeah, so his baseline is 1.0. So like you're saying, it is an AKI. So thank you for sharing your thoughts and joining. Excited for you to join us. how would you think about managing this AKI per se, or how do you think of the etiology of it?
I would think it is perennial because since we have like a heart failure and there will be like the decrease or reduction of the effective arterial circulating volume, which is caused by the disbalance in the Frank Starling like hydrostatic and oncotic pressures.
Yeah, and that's definitely one of the mechanisms and how patients with heart failure would have an AKI. Does anybody have anything else to add, or how would you think of the diuretics in relation to that? Because if we're saying they have decreased forward flow, do we worry about diuresing? Or should we just go ahead and give this patient furosemide per se? Rodrigue, do you want to share your thoughts and tell us a little bit about yourself?
Hello, everyone. Can you hear me?
Yes.
Yeah, good evening from Cameroon. I'm glad to be back after a while. Yeah, definitely. I think this patient will still benefit from Lasix. And the dose of Lasix in the context of AKI is a little bit changed because of the AKI. There is a rule about dosing Lasix in people with renal failure or AKIs, about 25 to 30 times the creatinine. So if I want to give a bolus to this patient, I'll probably go in for 60 as a bolus, because there is also congestion at the level of the renal tubules. So they might need, and we can't go PO, and if we go PO, she might also need higher doses because of bowel edema. That's where Lasix is being absorbed. So definitely this patient needs diuresis.
Rodrigue, thank you so much for joining and for sharing your thoughts. Exactly. So now we just talked about two mechanisms of heart failure causing AKI. So we talked about decreased forward flow in the arterial side, and Rodrigue just mentioned increased venous congestion causing decreased flow across the kidney. And a lot of times that is the primary mechanism. So if you go to the CP solver schema to AKI, and any intern who goes with me knows about my talk on AKI, I open the CP solver schema. And if you go to pre-renal, under pre-renal, you see there's volume up, but there's also volume down. And I hope to uncouple this idea of like pre-renal AKI is volume down per se, and that they need fluids. But a pre-renal AKI can be someone with heart failure who has excess fluid from the venous side who need diuretics. While on the other hand, someone who has been vomiting has pre-renal AKI but needs fluid. And these are two causes of pre-renal AKI that we're treating completely in opposite ways. Someone we're giving fluids and the other person we're giving diuretics. And a lot of times this is the mechanism in heart failure, and that the diuretic will actually help with the AKI or lower the creatinine. So like you all said, so we would start diuresing and hopefully follow the creatinine. Last two thoughts. Earlier we said that the hemoglobin was 10. What do you all want to do about that? Iron panel. So ask and you shall receive. So the ferritin is 200 and the transferrin saturation is 17.
Hello.
Yes, we hear you.
Yes. Anemia, especially iron deficiency anemia, has been proven to lower the quality of life in people with heart failure, especially heart failure with reduced ejection fraction. It is important to correct iron deficiency and iron deficiency anemia in those patients to improve their quality of life. So sometimes they are you need to give, I think it's fluorocarboxymal dose that has been studied, if I'm not mistaken. But yeah, sometimes they require IV ions. I think it's Kyoikli or I've forgotten the dosage regimen. They do benefit from intravenous ion therapy.
Perfect. And does anybody know the mechanism of iron deficiency and heart failure? Or like any idea of how we would get iron deficiency, or how you would guess? Yeah. Yeah, so we have propositions in the chat: anemia of chronic inflammation, venous congestion, so the RBCs extravasate, an imbalance between supply and demand, and it's been like postulated that it's usually multifactorial. So there is chronic inflammation, there is upregulation of hepcidin, there's also gut edema with decreased absorption, along with all of these factors are thought to contribute. And like you all said, there are studies that show that replacing iron can improve functional capacity, symptoms, quality of life for these patients. And one thing I want you to keep in mind is that we should not forget to our primary care hat on, is that anyone with iron deficiency anemia would, if they're in the right age group, would need colon cancer screening. And that is something we sometimes forget. And like, for example, this patient has a history of heart failure, so they might have an etiology for the iron deficiency, but you want to keep in mind, do I want to refer this patient for age-appropriate cancer screening with a colonoscopy and potentially AGD/H. pylori? That's if the colonoscopy is negative, but that's something to keep in mind as well. Lastly, I just wanted to propose this new idea, is that there's one of the post analyses of the dose trial, which was done to evaluate the dose of diuretics. In one of the analyses, they noticed that the patients who had a higher creatinine at discharge had a lower chance of getting re-hospitalized. And there's this new idea in that a hypercreatinemia, which is a new term coined in the last century, is like permissive hypercreatinemia, might actually be beneficial in those patients through two mechanisms. So the first mechanism is that these patients are volume overloaded, and the more dry you get them, they're less likely they're going to be hospitalized. And this blew my mind. It's like, I've been learning about AKI for all my life, and suddenly you tell me permissive hypercreatinemia. And that was actually shown to help, that the patients who are dry will less likely to be hospitalized per se. And the other thing is that there's this thought process that could the creatinine also be diluted, in the sense that when you're diuresing, are you unmasking a dilution, and that is just a number that you're unmasking, and that's where they should be per se. Thank you, Bea, for sharing this article in the chat about iron deficiency. That's all I had for today. I wanted to see if anybody had any questions or thoughts before we wrap up.
Yeah, so I'm not sure if you can hear me again.
We can.
Okay, I just had a question, maybe not regarding the teaching points themselves, but rather about the patient evaluation. My university hospital is a tertiary care center, and there's a cardiac center affiliated with that institution. And I remember when I was on my cardiology rotation, I know that in JVP, we learned that you should measure the angle and that you should use a ruler, etc. But in your case, or really anyone in this meeting, Do you usually do this thing when you're in clinic, or do you usually just depend on visual inspection of JVP pressure, and based on that, you assess the patient's fluid status?
Is the question if, sorry, please go ahead, Rodrigo.
Yes, it's not very practical to use a ruler or two hands. We really do. I myself, I do rely on visual inspection, and I use my hand. That is a technique I learned from Andre Manso. I think some of you are familiar with his website or his famous book, Frameworks for Internal Medicine. So yeah, I think it's more practical by the bedside. Like nobody uses a ruler anymore. This is 2023, so we usually rely on visual inspection.
And Rodrigo, what is the thing you talked about with the hand?
To use to know, first of all, know the width of your hand. Place your hand on the physical landmark, which is most of the time the angle of read, with the palm facing the patient and the thumb facing the ceiling, and then eyeballing the top of the column of your neck on the venous position to your hand, and try to figure out how many centimeters is you find the top of the column from the distance of the physical landmark. I hope my English is clear enough. I don't know.
It's perfectly clear. We understood every single word. So yeah, exactly. And to add to that is that if you press on the vein, and versus sometimes you might mistake it for the arterial pulse. So if you compress it and if it goes away, it's more likely to be venous, and that can also help you to assess, is this an arterial flow or is this a venous flow, other than the pulsation and the type of pulsation, but that's also one way to do it. So just to recap, to close this case and recap, so this patient was started on started on SGLT2 inhibitor and a beta blocker, and after he got daily weights, was diuresed, got his finally was diuresed with follow-up in cardiology clinic, and has been following for the past 6 months. They're now on all 4 of the GDMT medicines essentially, and they're functionally doing better, have not been hospitalized since that time. Do you want to go over the teaching points?
Yeah, I can definitely go over the teaching points if there's no other questions. But Yusuf, I just wanted to say a huge thank you to you for putting this session together and for coming with all of these teaching points. I personally have learned so much, and it was really awesome to see everyone's brilliant thoughts and thinking in the chat. So huge, just thank you to you, Yusuf. So I will kind of go through all the incredible teaching points. I may have missed something, but there's just so much there. So after the first aliquot, we were concerned that this patient had congestive heart failure, and we went through the signs that indicate left heart failure versus right heart failure. So left heart failure signs, you can think of pulmonary edema, crackles on auscultation, shortness of breath, bendopnea, which we learned was when the patient has shortness of breath when they lean forward to tie their shoes, for example. And actually bendopnea is associated with elevated filling pressures. So right heart failure signs include, ascites, so a distended abdomen, lower extremity edema, and jugular venous distension. We talked about how you can have progression from left heart failure to right heart failure. So when you have left heart failure, you have pulmonary congestion, which can lead to right heart failure, and then you can see the lower extremity edema. But Yusuf actually taught us that you can have edema with left heart failure alone. So the volume overload might cause edema without prominent signs of right heart failure. So to assess signs of perfusion, when we're trying to see, is this person warm or cold? Some signs you look for are oliguria, capillary refill, decreased pulse pressure, cool extremities, lethargy, ultramental status, tachycardia, elevated lactate, hyponatremia, elevated troponin. And we learned at the end here that to assess the JVP, Oftentimes, it's not so common to use a ruler, so you can rely on visual inspection. And we learned a really great pearl about being able to placing your hand with the thumb facing the ceiling to determine the number of centimeters. We talked about for kind of reviewing sensitivity and specificity. So sensitivity, those are tests that are like a highly sensitive tests are good to rule out a diagnosis. So for example, ANA and lupus, a highly specific test is good to rule in. So for example, if you have positive, 2 out of 2 blood cultures for staph bacteremia, that's pretty specific. And when we got to the labs, we talked about how this person had a normal sodium, but hyponatremia is associated with worse prognosis in CHF. I'll jump to the creatinine a little bit later and the hemoglobin as well. But for the BNP, we asked the question, is this specific for heart failure? And the answer is no, because any etiology that can cause kind of strain on the heart or dilation of the atrium ventricles can lead to elevated levels. So for example, a PE can cause right heart strain and lead to elevated BNP. Conditions like CKD can have higher levels, and obesity can lower the BNP. So Yusuf kind of reviewed for us that if you have an elevated BNP over 1,000, you really need to consider volume overload and CHF. If you have a BNP less than 100, heart failure is less likely. We also reviewed some triggers for new HFrEF. So really the most common causes are hypertension, CAD, and ischemia, as well as valvular disease. And some less common causes, but important to consider, are toxins and meds like doxorubicin, alcohol associated, and then some genetic causes. Ultimately, you want to try to classify the presentation as, is this person warm versus cold and wet versus dry? So the warm versus cold kind of referring to the perfusion. And classifying them as warm versus cold and wet versus dry really helps dictate management. So in this case, we thought this person was warm and wet. So we considered diuretics and also vasodilators. If a person is cold, for example, like decreased perfusion, signs of cardiogenic shock, that's when you really want to consider inotropes. So then we talked about GDMT, which is guideline-directed medical therapy, and this means that these are the therapies that have a mortality benefit for reduced ejection fraction. So Yusuf showed us a great mnemonic of BAMs, B-A-M-S, so including beta blockers, the A is ACE inhibitors, ARBs, ARNIs, M is mineralocorticoid receptor antagonists, and S is SGLT2 inhibitors. And really, when you're thinking of the timeline administration for HFrEF, you just need to think of like immediate GDMT. Some people have like rapid sequencing where you start with beta blocker and SGLT2 followed by the others, but really you want to start kind of as soon as possible. And then quickly at the end, I'll just review kind of the 2 ways heart failure can lead to AKI. So the first is a pre-renal picture, so decreased forward flow. And the second is venous congestion causing decreased flow across the kidney, which I believe Yusuf said was actually the primary mechanism. But in the setting of AKI and diuresis, diuretics do help. What else? We talked about iron deficiency in the setting of heart failure, and we reviewed that that's multifactorial, including anemia of chronic disease, gut edema with decreased absorption, and replacing iron can improve quality of life and functional capacity. Then at the end, we learned a really interesting concept about kind of a higher creatinine at discharge is associated with a lower chance of being hospitalized. So basically kind of permissive hypercreatinemia might be beneficial. And the 2 mechanisms for that, one was that volume overload. Let's see. Yusuf, maybe you can summarize this because I didn't quite understand those last 2 mechanisms. So you can summarize those last 2 points.
Yeah, so increased inflammation in general with a chronic inflammatory state, which is like through the upregulation of hepcidin in the liver and essentially anemia of chronic inflammation.
Awesome. Well, thanks, Yusuf.
Maddie, that was amazing. Thank you so much for doing the teaching points. We now have an hourly session about the cellular mechanisms of heart failure. No, I'm just kidding. That's the April Fool's joke. I just wanted to say in the chat that people who joined us today are from Italy, USA, Cameroon, Egypt, Brazil, Sweden, Indonesia, Pakistan, Bahrain, from all over the world, Colombia. And as you've noticed, this is like really, really democratizing the medicine. We are evaluating patients with heart failure across the globe, and we're all doing it the same, which is absolutely amazing. And I just want to tell the listeners who are on YouTube is that we are doing this every single day, and we're doing this at different times during the day, and we are learning so much. And I've grown so much as a learner just over the past couple of months by joining these sessions. And I can show you how to sign up on the CP Solvers website. So essentially you go to the CP Solvers website and you go under Join Live, and then you say, you can scroll here and you can email this link, for example, and you will join for the morning reports. And as I said, these are happen daily. And as a community, we're all like growing so much. And I'm very, very, very grateful for this team and everyone who has joined. And I love to see the love for knowledge. And this is all for free. We're all doing this out of like the passion and the love for learning and medicine. And I know how all of you are extremely passionate about this, and we want to use this knowledge to care for our patients. And that's the driving factor for all of us. And I'm so glad to share this space with you all. So thank you.